and excretion of the drugs. And there is only limited research is going on in this field, which causes lack of sufficient clinical trials in this population. And balancing the maternal need for medication with the fetal and infant safety is another challenge. The key principles of rational pharmacotherapy are: ensure the medication is necessary for the mother's health, and choose a drug that is effective for the clinical condition, and prioritize medications with the least risk to both mother and child. Consider ease of use, patient education, and adherence. In first trimester, we have to consider the organogenesis. So teratogenic drugs should not be used. Adjustment may be needed for drugs in second trimester and third trimester because it may affect the placenta and fetal development. Then a few words about pharmacotherapy during lactation. The drug transfer, mechanism of drug transfer is depending on the lipid solubility, molecular weight of the drug, etc. And age of the infant, timing of the drug administration, and the drug's T-half is also affecting the safety. During lactation, we prefer drugs with low transfer to breast milk and minimum impact on the infant. Avoid drugs with long T-half and high plasma protein binding. Monitoring and follow-up is essential. Maternal response, we have to monitor, ensure the medication is achieving its intended effect, and we have to monitor the infant, assess any signs of adverse effects from the medication, like sedation, feeding difficulties, etc. And timing and duration is also important. Educate patient on the timing of the drug administration. Example, taking medications just after breastfeeding to minimize drug levels in milk. And drug categories in pregnancy and lactation. We all are familiar with the FDA, the earlier historical FDA pregnancy categories like A, B, C, D, X, but it is no longer used now. FDA implemented the pregnancy and lactation labeling rule in 2015. It is a more detailed, narrative-based system designed to provide more useful information for healthcare providers. Balanced risk assessment. Healthcare providers must weigh the potential benefit and risk of the medications, taking into account the severity of the mother's condition and the stage of pregnancy or lactation. And now we are moving on to management of common diseases and conditions in pregnancy and lactation. First of all, the most common, upper respiratory tract infection. Most of the time, antenatal woman approaches family physician for their mild symptoms like upper respiratory infection and all. So we are the one to treat them safely. For fever and headache, we can use acetaminophen. NSAIDs are contraindicated because it will cause heart defects in the infant. For cough suppression, we can use, for dry cough, dextromethorphan can be used, and for expectoration, guanfacine is good. Silometazoline and oxymetazoline as decongestant. Antihistamines like first generation antihistamines, diphenhydramine and chlorpheniramine are safe. And the second generation medicines like loratadine, cetirizine, fexofenadine can also be used. In case of chronic allergic cough, intranasal corticosteroids are indicated. Then about the gastrointestinal symptoms. For vomiting, the preferred drug is doxylamine plus pyridoxine. And in case of severe nausea, we can use ondansetron also. For GERD, H2 antihistamines like ranitidine can use. PPAs can be used, but there is some studies which shows some risk to omeprazole. For constipation, osmotic laxative, fiber preparations, and probiotics can be used. Antacids containing aluminum, calcium, and magnesium are safe. Diarrhea, in case of severe diarrhea, we can use loperamide. One of the most challenging situation is pain management in pregnancy and lactation. The first line analgesic is acetaminophen. It is for it is safe for short-term use only. We should not be used for long-term uses. And NSAIDs are generally contraindicated, but ibuprofen can be used in second trimester. If it should be avoided in the third trimester due to risk of premature closure of the ductus arteriosus. Opioids used for severe pain only and under close supervision due to the risk of neonatal withdrawal syndrome and long-term effect on the infant. Management in lactation, pain management in lactation, acetaminophen and ibuprofen are both considered safe. And opioids like hydrocodone and morphine can use with caution and for the shortest duration. It will pass into the breast milk, causes sedation and respiratory depression in the infant. Topical treatments like topical lidocaine and heat pads can be used. Then management of hypertension in pregnancy. The first line is methyl dopa, and we can use labetalol, a beta blocker with the alpha blocking property, and extended release nifedipine. We should not use immediate release formulations because it will cause potential maternal hypotension. Hydrolazine used in emergency situations, particularly for acute hypertension or preeclampsia. Management in lactation, the same medicines, methyl dopa, labetalol, nifedipine, and hydrolazine. We should avoid ACE inhibitors, ARBs, and diuretics in case of pregnancy. It will cause fetal renal development, defects in the fetal renal development and electrolyte disturbances in the baby. In case of gestational diabetes mellitus, insulin is the first line. It does not cross the placenta. Metformin is the oral medication we can use. It may cause placenta but in very small amount and does not show much of side effects. Glyburide is another oral agent, but more preferred is insulin and metformin. We should avoid sulfonylureas. Then about the infections during pregnancy and lactation. The most common infection is urinary tract infection. It is due to the hormonal changes affecting urinary tract functions. The first line treatment is penicillins and cephalosporins, but most of the times the bacteria will be resistant to mouse club and all, so we have to consider cephalosporins. We should avoid fluoroquinolones like ciprofloxacin. It will affect the cartilage of the fetus, and avoid cotrimazole in the first trimester due to teratogenic risk. In case of pyelonephritis, we can use ampicillin plus gentamicin, ceftriaxone, cefepime. And in patients having penicillin beta-lactam hypersensitivity, we can use aztreonam. For fungal infections, topical agents are preferred, like clotrimazole. Systemic antifungals like fluconazole should be avoided. For varicella, we can use acyclovir. Scabies, permethrin can be used. Antibiotics to be avoided in pregnancy are tetracycline, doxycycline, metronidazole, chloramphenicol, and aminoglycosides. Then about the mental health conditions in pregnancy and lactation. The primary first-line treatment is cognitive behavior therapy for mild to moderate depression. In case of if we have to use the antidepressant, the preferred one is SSRIs, selective serotonin reuptake inhibitors like sertraline and fluoxetine. But we should avoid paroxetine. Other options are SNRIs like venlafaxine, tricyclic antidepressants like amitriptyline. In lactation, we can use SSRIs like sertraline, fluoxetine, paroxetine, and tricyclic antidepressants like amitriptyline and nortriptyline. We should avoid benzodiazepines during lactation. It is due to the risk of sedation in the infant. The management of anxiety is first we have to opt for non-pharmacological methods. In case if we have to use medicines, then SSRIs and short-term benzodiazepines are indicated. Thyroid disorders, hypothyroidism, you can safely use levothyroxine, and we should monitor thyroid functions throughout pregnancy. Hypothyroidism, propylthiouracil is preferred in the first trimester and methimazole in the second and third trimester. Medications for asthma in pregnancy. The first line is short-acting beta agonists like salbutamol. Then we can use inhaled corticosteroids, budesonide and beclomethasone. And leukotriene antagonist, receptor antagonists like montelukast can be used. Second line agents are LABAs, salmeterol, formoterol. Theophylline have narrow therapeutic index and potential side effects. So it is generally used with caution. We can use it, but we should be cautious. The medications to avoid are oral corticosteroids like prednisolone. Short-term use may be needed in case of severe asthma exacerbations. Then about the epilepsy in pregnancy, the safer drugs are lamotrigine and levetiracetam. In case of if that is not effective, then we can use carbamazepine or oxcarbamazepine with some risk. We should avoid phenytoin, topiramate, and phenobarbital, and valproic acid is contraindicated. And a few words about rheumatoid arthritis. SCQS means hydroxychloroquine and sulfasalazine are safe during pregnancy, but contraindicated medications are methotrexate, leflunomide, and biologicals. The key takeaways are we should select the drug which should be safe and prioritize evidence-based guidelines and safe alternatives. We may need a multidisciplinary approach, collaborate with the obstetricians, pediatricians, and other specialists when necessary. And patient education is very important. Inform the patient about potential risk and benefits of medication and the importance of adhering to prescribed therapies. And there is need of more clinical trials and better evidence in these special populations. So, we have a question. Which of the following medication is considered first line for managing hypertension in pregnancy? Option A, B, C, D. You are right. Option A, methyl dopa is correct. Then question 2, which of the following medication is considered safe for breastfeeding mothers? Codeine is an opioid, tetracycline is an antibiotic, diazepam, benzodiazepine, sertraline, SSRI, which one is right? C, sertraline is safe during lactation. Other medications are not safe. In the management of pain during pregnancy, which of the following is generally considered safest option? Easy question. Acetaminophen. What is the problem with ibuprofen at third trimester? Yeah, premature closure of ductus arteriosus, and naproxen during second trimester will lead to cardiac defects in the fetus. These are my references, and thank you for your patient listening.
We'll take questions at the end of the session together.
Thank you, ma'am. We request the chairperson to invite the speaker for the next session.
Next session is novel iron therapy. Welcome Dr. Indu Rajiv. She is someone who needs no formal introduction. Shall we go on to the presentation, ma'am?
Thank you, Namita. Good afternoon, all. Mine is actually a sponsored talk for the company ANEOS. This company has been supporting AFPI Kerala Chapter for the past 7 years, and I thank them for that. So my topic is about a new oral iron agent called Fernios, which has come out with a revolutionary technology. The name is microspherical ferric pyrophosphate. Coming to iron deficiency. Iron deficiency, it affects millions of people globally, and it affects many demographics. And the available iron treatments are oral iron, IV iron, and erythropoiesis stimulating agents. And the new technologies are liposomal, microspherical ferric phosphate. There are other technologies like ferric citrate, a phosphate binder, and sucrosomal iron with nanotechnology also are coming. So this is another new technology. And according to the Ministry of Health and Family Welfare, you take the children and the non-pregnant women and women, more than 50% of the people are anemic. Whereas in men, around 22.7% between the age 15 to 49 years are anemic. And the prevalence of anemia is higher in India compared to other developing countries. And it's also the second leading cause of maternal death in our country. Now, what is the current management? Oral iron tablets, right? All of us give oral iron tablets. And it is very easy to use oral iron because it can be given without any much supervision. It's the first line of treatment. Unlike intravenous, it needs less supervision. It is more accessible and very convenient also. And the newer preparations have, like what I told you, the microspherical ferric pyrophosphate. They have enhanced absorption, fewer gastrointestinal side effects, thus improving the patient compliance, and it's useful in the long-term management of anemia. Now coming to distribution of iron in the body, iron is essential body constituent. The total body iron in adult is around 2.5 to 5 gram. It is more in men than women. It is distributed as follows. In the hemoglobin, around 66%, as ferritin and hemosiderin 25%, myoglobin 3%, parenchymal iron is around 6%. And iron participates in oxygen transport, enzyme production and activity, and protein synthesis. It is present in two forms, the heme iron and the non-heme iron. And what are the dietary factors affecting the bioavailability are the phytates, polyphenols, calcium, oxalic acids, they are all the inhibitors, whereas enhancers are the heme iron and the ascorbic acid. And how to improve the bioavailability improvement is by encapsulation, emulsification, chelation, and nanoparticulation. The daily requirement of iron in a male is around 13 milligram per kg, in a female menstruating around 21 mg per kg, infants around 60 mg per kg, children around 25 mg per kg, and pregnancy last 2 trimesters are 80 mg per kg. So requirements are very high in pregnancy, as you all know. And iron absorption, the daily diet is around 10 to 20 milligrams of iron, and absorption is from the intestine, the most upper part, the duodenum and the jejunum. The two major forms of dietary iron are the heme in red meats, non-heme iron in the plant foods, and all the dietary iron is in the ferric form. It has to be reduced to the ferrous form before absorption. And absorption is by two separate iron transporters in the intestinal mucosa. This is a divalent metal transporter, DNT1 and a ferroportin. Now, when there is a low dietary iron, what happens is it's taken up by the enterocyte into the cell, and with the divalent metal transporter, it is transported outside the basolateral membrane. It goes to the ferroportin and it is into the plasma. But there are certain conditions like inflammatory conditions or high iron levels which can cause the release of a hormone from the liver called hepcidin. It's a hepcidin pathway. So whenever there's a high iron level or an inflammatory condition, hepcidin is released, and what happens is it blocks the ferroportin, and it forms a complex with the ferroportin. This hepcidin forms a complex with the ferroportin, and it enters the cell, and it's internalized and it is destroyed by the macrophages. In that way, the iron levels are kept to normal. So how is it regulated? Hepcidin level, it regulates iron stores and the plasma iron levels. And in inflammatory conditions, the inflammatory cytokines induce hepcidin biosynthesis. The level of hepcidin becomes very high so that the iron does not get absorbed. That's why in conditions like CKD, in chemotherapy patients, in dialysis patients, you see anemia because of the high hepcidin level. There are other conditions like even COVID conditions where the inflammatory levels, or even sepsis conditions where the hepcidin level is very high and it blocks the iron absorption. Iron is utilized for hemoglobin synthesis and also protein. Now the therapy gap with the usual iron preparations are low absorption rates, gastrointestinal side effects, and the delayed response. So they have come up with a revolutionary technology called microencapsulation, so that every dose is optimized for peak performance and minimal side effects. So this process of microencapsulation is available even for food supplements. If you go to the market and see, there are certain food supplements which are done in similar way where it can be absorbed and gives more bioavailability. So similar thing has been used for this drug. So it is a process by which tiny particles or droplets are surrounded by a coating. That is a phosphobilipid layer, and there is a matrix covering the phosphobilipid layer, so that it is taken up by when you take this tablet, it's taken up by the M cells. It's not the usual DMT or the ferroportin. It is taken by the M cells and directly enters into the systemic circulation, thereby bypassing the hepcidin pathway. So advantages, it is ideal for supplements. This microcapsule withstands homogenization, pressure and temperature, genetically modified organism free and without preservatives, and thus there is a high bioavailability. So indications are iron deficiency anemia associated with CKD in pre-dialysis, dialysis, transplanted patients with anemia, iron deficiency anemia in pregnant, non-pregnant, inflammatory bowel disease, and chemotherapy patients. So this is a clinical trial with the drug micronized encapsulated ferric pyrophosphate in iron deficient CKD and the gynec anemic patients, in the gynae anemic patients. So here the study population around 60. The primary objective was to determine the efficacy in patients with iron deficiency anemia, improving the hemoglobin level. Secondary objective was to determine the efficacy in patients with iron deficiency anemia and improving serum ferritin and the transferrin levels. Tertiary objective was to evaluate the safety and tolerability. So each tablet contained 30 mg of micronized encapsulated ferric pyrophosphate. The subjects were CKD patients and the gynec anemic patients. The mean age group in the gynae patients, female 52 years, mean weight 54 kg. In CKD patients, the mean age, males were taken, mean age was 50 years and mean weight was around 58 kg. And dose and mode of administration was the subjects were advised to use once daily after breakfast over a 12-week period. So the endpoints were, there was a significant outcome for all the endpoints. You can see the hemoglobin level from the baseline from 8 to 12.2. By 90 days, it raised around 12.2. If you see the MCV, from base 76 to 79.9, MCHC from 29.8 to 31.5 over the 90-day trial. Change in MCH from 27.3 to 28.6. And the red distribution width came down from 19 to 15.3. Normal is less than 15.3. So the p-value was also significant for every values. And regarding the endpoints for serum ferritin transfer saturation, RBC and PCV, again, the change in ferritin baseline from 17.2 to 18.4 on day 90, transfer saturation 15.6 to 16, RBC levels from 2.6 to 4, PCV from 23.9 to 36.2. So there was a significant outcome for all the endpoints, and the p-value was also significant. Now, regarding the safety assessment, the liver, renal function, vital signs, physical parameters, and the physician's global assessment of response for therapy, that is PGART, you can see the liver and renal functions, SGPT, SGOT, ALP. From the baseline, SGPT actually came down to 28.7 from 31.8. Alkaline phosphatase was also showed a significant improvement, like 108 to 104. It never went to the higher side. SGOT 26.9 to 24.9. Again, the p-values are very significant. Urea creatinine also showed improvement actually. Creatinine values dropped from 1.4 to 1.3. Bilirubin dropped from 1.4 to 1.3. Vital signs and physical parameters, no changes were observed during the study. And physician global assessment of response to therapy, around 70% rated that this therapy was as good to excellent. Now the size, this is a histogram showing that the size less than 100 micrometer, anything less than 100 micrometer, the bioavailability of the drug was very high. Anything less than 100, the bioavailability was very high. Now coming to the salient features of the highly bioavailable ion, it had excellent, you saw the study, excellent physical parameters. Safety and efficacy was established in Indian patients. It's highly stable, non-reactive due to the lipophilic coating, highly bioavailable, absorption via the intestinal M cells, and clinically proven to increase the serum iron, hemoglobin, and reduce the anemia. Now it's available in America and Asia too. And coming to the United States pharmacopoeia of Ernios, highest uniformity coefficient of the particle size to ensure repeatability in absorption. And the pharmaceutical index, that is the active pharmaceutical index concentration compared to the competition. The tablet size was very small. Only product to be studied in Indians with chronic inflammatory conditions. The safety and efficacy established in Indian CKD patients result improving the renal and the liver functions, and absorption via the intestinal M cells was proven. Now this is an electron microscopic study which was, it was done in using the U937 cells. It was incubated with these cells, and it was found that you can see the black concentration of the drug around the cells. This iron liposomes penetrated easily into the cells and internalized by the U937 cells without inducing any cellular damage and preserving the morphology. This is about the study. Thank you.
Thank you, ma'am.
Thank you, ma'am. We request the chairperson to invite the speaker for the next session. Over to you, ma'am.
Can I invite Dr. Aishwarya on the stage, please? The topic will be managing rectal bleeding in primary care, a practical approach. Dr. Aishwarya is a specialist family physician. She practices at KIMS Health, Trivandrum.
Okay, good afternoon, everyone. My topic is managing rectal bleeding in primary. One second. Okay, so my topic is managing rectal bleeding in primary care, a practical approach. So what is the definition of rectal bleeding? Rectal bleeding means bleeding from a site distal to the ligament of Treats, and it is a manifestation of lower GI bleeding. This is the diagram. Then lower GI bleeding can be mild or intermittent, as in case of angiodysplasia, that is presence of abnormal blood vessels, and colon cancer, or moderate and severe, as in case of diverticula. However, colon cancer rarely causes significant lower GI bleeding. Now coming to the pathophysiology, rectal bleeding can be overt, occult or obscure. Overt means it can be acute, massive or chronic. Acute GI bleed can present as melena, that is dark, tarry, foul-smelling stools as a result of degradation of hematin, or as hematochezia, that is passage of maroon or bright red blood and blood clots per rectum with or without stool. Occult bleeding means bleeding that is not apparent to the patient. It is usually detected with testing. So the most common presentation of lower GI bleeding in the older adult is occult bleeding. Remarkably, patients can lose up to 100 ml of blood per day and can still have grossly normal appearing stools. Next is obscure bleeding, that is bleeding in which the source is difficult to detect on routine endoscopy and radiological examination and can even remain unidentified. Now coming to the causes of rectal bleeding, 80% of the causes are due to colorectal causes like diverticular disease, angiodysplasia, neoplasm, inflammatory bowel disease, ischemic colitis, radiation proctitis, and anorectal diseases like hemorrhoids and fissures. Small bowel causes include Meckel's diverticulum, AV malformation, inflammatory bowel disease, and neoplasia. Upper GI source accounts to 10% of the causes, which includes vasculitis, gastric ulcers, and neoplasm. So just another slide of causes to show the diagram and the sites, most commonly occurring sites. And coming to the incidence, that varies with age. For example, for a patient less than 30 years of age, the most likely causes are hemorrhoids, anal fissures, inflammatory bowel disease. And for patients above the age of 50 years, there's a higher risk for colon cancer. Prevalence is more common in men than women, and worldwide regional differences also exist. For example, in a person presenting with rectal bleeding in the West, like in US, the most common cause can be diverticular disease, whereas in India it can be either hemorrhoids or colorectal cancer. There are some other factors that affect the severity of bleeding per rectum in elderly, like the presence of comorbid diseases like cardiovascular disease, diabetes, malignancy, and also polypharmacy, that is, use of NSAIDs and anticoagulants. Now, coming to the assessment of the patient, the primary assessment includes, of course, taking a detailed history. That is, presenting complaints. We have to ask about onset, duration, frequency, aggravating and relieving factors. For example, whether the patient is straining while passing stools, then the character of bleeding, and symptoms that are suggestive of hemodynamic instability, and the presence of pain, history of constipation, etc. Just some pointers. If a patient presents with pain and bleeding, the cause is most likely to be fissures. If there is a pain, lump and bleeding, it can be prolapsed piles, carcinoma of anal canal, prolapsed rectal polyp or a prolapsed rectum, or carcinoma. If there is no pain and blood is mixed with stools, it can be carcinoma colon. If there is a blood streak on stool, it may be a rectal cancer. Blood after defecation mostly points to presence of hemorrhoids. Blood and mucus can suggest presence of colitis along with other features like abdominal pain. And blood alone is usually occurs in diverticular disease, and melena occurs in peptic ulcer. So history is very important. Family history is also equally important. Family history of malignancy or familial adenomatous polyposis. Then drug history, we have to take a detailed drug history, whether the patient is taking anticoagulants like warfarin, use of NSAIDs. And social history, whether the patient is taking a low fiber diet, whether there is history of smoking, etc. Now, red flags. We should be well aware of the red flag signs, which include weight loss. Weight loss, significant weight loss means more than 5% weight loss in the last 3 months, or more than 10% weight loss in the last 6 months. Then anemia is a red flag sign. Change in bowel habits, mostly towards loose stools. Then palpable abdominal mass is a red flag, palpable rectal mass, and age above 55 years. Physical examination includes the examination along with the general examination to look for pallor, etc. We have to examine the abdomen to exclude abdominal masses. And digital rectal examination is also very important to examine for rectal masses, fissures, and to exclude rectal cancer. So rectal examination has 3 components. One is the local examination, which is the external examination. Then there's digital rectal examination and proctoscopy. Proctoscopy is done using a proctoscope and obturator, which gives an idea of around 10 to 13 centimeter of rectum and anal canal, and it can help to rule out local pathology. Now come to the investigations. Baseline blood investigations should be done like the complete blood count, serum electrolytes, renal function test, liver function test. Coagulation profile is very important. Blood group and cross-matching is also important, and also various tests based on the presenting symptoms of the patient. Stool examination is required to look for ova or trophozoites of amoeba if symptoms are suggestive of a parasitic infection. Then fecal calprotectin is a useful screening tool in younger low-risk patients with suspected inflammatory bowel disease. A positive fecal calprotectin test has a higher positive predictive value for finding inflammatory bowel disease at colonoscopy and is also cost-effective, but it is not a substitute. Proctoscopy is useful for primary care physicians as a screening tool in patients with rectal bleeding. However, as I said, it should not be used as a substitute to imaging or colonoscopy to rule out serious pathology like cancer. Now coming to secondary investigations, which are usually done on referral, that include, along with proctoscopy, it includes sigmoidoscopy, colonoscopy is very important. Then isotope scans may be done with patient's own RBC tagged with 99M technetium. Abdominal scanning by gamma camera can identify the site of bleeding. Angiography is another invasive procedure that is done as secondary investigation. And also contrast radiography like double contrast barium. And lastly, laparotomy. So, for a family physician, the initial evaluation should focus on obtaining the patient's history and performing a physical examination and including the evaluation of hemodynamic status. Subsequent evaluation should be based on the suspected etiology. Now coming to a few common causes that we encounter in our practice. Hemorrhoids. The management includes lifestyle changes, increasing fiber and fluid intake, exercising and practicing regular bowel movements. Local application of hemorrhoidal creams, which is a combination of analgesic, anesthetic and anti-inflammatory, which has anti-inflammatory properties. And medical management include giving stool softeners, fiber supplements, and oral calcium dobislate. For example, 500 mg twice a day for around 5 days may be given. Tranexamic acid or flavonoids like diosmin are also advised for control of bleeding. Then surgical treatment options, if you are not able to manage further, includes rubber band ligation, sclerotherapy, infrared coagulation, and surgical excision. Another common cause that we encounter is anal fissures. It is acute, means it's a tear in the skin of the anal canal. It may be treated by dietary advice, bulking agents, fluids, anti-inflammatory drugs, etc. Chronic symptomatic fissures, that is more than 6 weeks duration, may benefit from topical GTN 0.4% application with appropriate advice on application and duration of treatment. Side effects include vasodilator effect that can cause headache or dizziness. The topical calcium channel blockers like 2% diltiazem cream is another alternative. Anal fissures with atypical appearance or clinical signs of chronicity with scarring or tags should be referred. Then diverticular bleeding. It usually occurs when a small artery located within the diverticulum is eroded and bleeds into the colon. It is usually painless bleeding, maroon or bright red with bowel movements. It is diagnosed via colonoscopy and imaging modalities or barium enema. We should give an advice on high fiber diet, plenty of fluid intake, physical activity to avoid constipation or straining. Medical management includes anti-inflammatory medications, antispasmodics, antibiotics, and other supportive measures like a liquid diet for a short duration. Inflammatory bowel diseases like Crohn's disease and ulcerative colitis. Symptoms usually involve having abdominal pain, bloody diarrhea, weight loss, and fatigue. There can also be extraintestinal features. Management includes anti-inflammatory medications, aminosalicylates, immunomodulators, and immunosuppressants, as well as symptomatic management. Lifestyle modifications include taking a low-fiber diet, vitamin and mineral supplementation. Surgical management may be required, and follow-up is also very essential. So according to NICE guidelines, referral criteria include any of the following patient with rectal bleeding should be referred urgently under the 2-week wait period. That is, patients with age more than 40 years with rectal bleeding and change in bowel habit towards loose and or more frequent stools for 6 weeks or more, and age more than 60 years with rectal bleeding persisting for 6 weeks or more without change in bowel and without anal symptoms. Rectal bleeding and palpable rectal mass should be referred. Treatment for minor bleeding, it is treated on active basis. Massive bleeding, should be treated on emergency basis. Resuscitation may be required. And investigations like colonoscopy or angiography to localize the source of bleeding and to stop bleeding is required. So a referral may be required. If all measures fail, surgical intervention is done. Now, follow-up and prevention. We have to monitor for recurrence. A regular follow-up is essential. Regular follow-up appointments to monitor for recurrence of bleeding or other symptoms. Then screening for colorectal cancer is important. Regular screening, colonoscopies or other tests to detect colorectal cancer early should be advised. Dietary modifications, we should encourage a high fiber diet, adequate hydration and regular exercise to prevent constipation and promote bowel health. Smoking cessation should be advised. Okay, thank you. I think we have some more time left. I'll just ask 3 questions. A 70-year-old male presents with rectal bleeding and anemia. He has a history of colon cancer in his family. The most appropriate initial test for this patient is A, CT scan, B, complete blood count, C, barium enema, and D, colonoscopy. The answer is colonoscopy. Next question. A 25-year-old woman presents with rectal bleeding and diarrhea. She has a history of travel. The most likely cause of her symptoms is A, inflammatory bowel disease, B, infectious colitis, C, irritable bowel syndrome, D, colorectal cancer. Correct. The answer is infectious colitis. The last question. A 50-year-old man presents with rectal bleeding and abdominal pain. He has a history of smoking and hypertension. The most likely causes A, diverticulosis, B, inflammatory bowel disease, C, colorectal cancer, D, hemorrhoids. Smoking actually increases the risk of diverticulosis. Okay, so thank you.
Thank you, ma'am. So this brings the session to close. Now, I kindly request the chairpersons, Dr. Jyotika and Dr. Namita, to present the mementos to the speakers.
Are there any questions from the audience for any session? Then we can wrap up.
Dr. Nusebat Kottadan. Dr. Indu Rajiv. Dr. Aishwarya V. Nabudiri.
I would like to invite Dr. Sarin Pilakadatte, consultant family physician, to present the mementos to the chairpersons. Founder, AFPI Secretary. Thank you.
Now we are moving to the final session of the day, that is the quiz finals, which is conducted for PG students throughout the state. Today morning we had a prelims for PG students. Actually, 26 teams participated from various hospitals and medical colleges throughout the state. I congratulate all the participants for being actively involved in the quiz competition conducted today morning. Now we are going to announce the winners of that prelims conducted today morning, and these winners will be competing for the prizes here. We have 5 winners from the prelims who is going to be there in the final rounds. The first team to qualify is who has secured 5th position, Dr. Faiza and Dr. Arya R from Trustwell Hospital, scoring 38 points. The 4th team to qualify is Dr. Aravind Krishnan M and Dr. Jay Ganesh S from Kim's Health Trivandrum, scoring 40 points. The 3rd team to qualify is Dr. Musliha and Dr. Misnya from VPS Lakeshore Hospital, Kochi, securing 43 points. The 2nd team to qualify the finals is Dr. Aisha Tasneem KP and Dr. Akila P from Narayana Hridayala, Bengaluru, scoring 43 points. And the first place in the prelims goes to Dr. Jewel Maria Primes and Dr. Jumana Haseen from Medical Trust Hospital, Kochi, scoring 50 points. A big congrats to all the winners who has secured their spots in the finals. We are entering to the quiz finals, which is happening within a couple of minutes. The winners will be awarded with 10,000 rupees cash prize and the award. Second place will be awarded 5,000 rupees and an award, and third place will be awarded with 3,000 rupees and an award. And congratulate all the participants who have actively, all the 26 teams who have actively participated in the quiz competition. Now the quiz competition will be conducted by our quiz masters for the day, Dr. Zerin and Dr. Serin Kuriakos, and also Dr. Nadeem.